Welcome back again to the endoscopic ear episodes. This case is a patient with cholesteatoma recurrent ear infection. So we're gonna do a combined endoscopic microscopic tympanomastoidectomy. And as usual, the injection of the ear canal, starting with the elevation of the tympanomeatal flap. As you can see, this is my trainee is elevating the tympanomeatal flap as usual from the 6 to 9 o'clock, the same way using the rosin knife and the combo. Try to preserve as much from the skin of the ear canal, breaching the upper part of the ear canal skin. Usually a relief of the going inside the middle ear cavity comes as the rivenous notch, just around the chorda tympani insertion. Okay, and then exploration of the middle ear cavity was carried out. As you can see, the cholesteatoma was surrounding the ossicles and just below the chorda tympani, and was in the sinus tympani, facial recess, and the foot plate. So we continue at the dissection of the tympanic membrane. What you can see, this is just a remaining of the incus. We breaches the milius in this case and dissect around. What I was trying to do is just to see what is the extent of the cholesteatoma and whether the fissure nerve is exposed or not. So I managed to dissect the sac over the foot plate, as you can see here. And from the sinus tympani. So I've removed part of the cholesteatoma from the sinus tympani. Up again. Over the foot plate again. And you can see it's clear, and my aim mainly was to check the fissure nerve, just to see whether it has been exposed or not. So we managed to dissect the skin over the fissure nerve. We didn't find any of the stable superstructure or the remaining of the incus there. From the scans already, we have seen that the cholesteatoma was really involving the mastoid antrum and going beyond the dome of the lateral semicircular canal. So again, to widen our space in the attic, to get space to clean the attic, we remove the head of the milius again, and the cutting of the tensor tympani. This makes a nicely reflected drum that gives us a space to work in the upper part of the ear canal, or the pars flaccid area. Okay, this is the chorda tympani again. Try to preserve it as much as we can, but most of the time we cut it. And then again, tensor tympani, cut it. I used the second knife most of the time, but in this case I was confident to do it because the fissure nerve was completely cleared up. Okay, reaching the anterior epitympani, dissecting the skin from the anterior epitympani, reaching the cock area. You can see the anterior epitympani is or the anterior tympanum is cleared, reaching to the cochleariform process. Okay, again trying to keep the core there as much as we can, Eustachian tube. Okay, and there is the supratuber area and the anterior tympani, it was cleared. This is the core area that I'm trying to clear up. Sometimes you need to drill this bit or get it getting a small curer to remove it. Yeah. So just removing the cork just to make sure that there is no skin fold in this area that has been left back. And as you can see, working in the middle ear cavity save a lot of time, especially if even if you're gonna do a cortical mastoidectomy for those patients. This case, I know that the video is around 15 minutes, but actually the whole case from the start to the end, so took us 1.5 hours, or almost 2 hours from closing to opening and put the patient for sleep. So we clean most of the anterior epitympanum. As you can see, just starting the drilling again. Removing part of the tympanic, the ear canal, just like a meatoplasty, small meatoplasty, not really meatoplasty, but I can call it a meatoplasty because all of the surgery is minimal invasive. And again to check. As I said before, from the scans, it's already seemed to be, it's beyond the lateral semicircular canal, so there is a skin there. But still, we try our best not to do the cortical unless they're really necessary, because we can't left any of the skin beyond this area. And if you doubt that the skin is going very deep, I would say not to drill much from the ear canal, so this will save a time for reconstruction as well as save you the reconstruction for yourself as well. So we decided to go for the cortical, just rapid cortical mastoidectomy as usual to